my name is Kim Cornelius, and this is my presentation for my nursing capstone for Dr. Hensley, fall 2019. For my project, I chose stroke recognition and prevention, highlighting the risk factors, signs and symptoms, and educational standards for monitoring of potential stroke patients. Before we get started on the PowerPoint, I would like to address the questions at the beginning of the rubric. So I created slides for the questions, and the notes that you can see on them are my personal notes that I use to answer the questions. For my practicum setting, I chose a level 1 trauma center. So to get started, I met with Ms. Kim Ferris, the education coordinator, and received an introduction to an existing project that she already had in the works. That project was carotid intervention involving the neuroassessments of carotid endarterectomy patients both pre and post-operatively. To get started, I began searching for literature in the medical center library. I also visited the Don and Kathy Jacobs Health Education Library found on the first floor, and I received an introduction to the CRAMES database. I was also introduced to the pre-op and PACU settings. Again, this is a level 1 trauma center. Approximately 80 plus surgical cases are performed here Monday through Friday. However, this institution never closes. It is open 24 hours a day, 7 days a week, and 365 days a year. The pre-op and PACU areas are 2 large neighboring units that include 77 patient beds, and the staff in these areas handle a diversity of patient populations, including pre and post surgery, floor crashes, ICU bed holds, boarders, etc. For my specific learning objective, I wanted to learn how we assess carotid endarterectomy patients both pre and post operatively. Where do we stand as an institution on how we educate our nurses regarding these assessments, and what practices are in place and how are they evolving? In the efforts of answering these questions, I spent a lot of time observing nurses in action. With the help of Ms. Ferris, I was introduced to just how large of a project this truly is. It not only involves the education department, but it is a multi-professional team that extends enterprise-wide. In this instance, a questionnaire was developed to establish a pre-teaching baseline and will be administered again post-teaching to determine if the teaching was successful. While completing my practicum hours, I was able to see the NIH stroke assessment in action, which was a very positive experience for me. You must be trained in order to perform the assessment. I have not been trained, so I cannot personally perform that. The rationale behind the assessment is that patients may have pre-existing deficits that need to be explored and need to be documented. A baseline is established, and in this case, it's established pre-operatively. The patient is then handed off to the operating room nurse. It is that nurse's responsibility to call report to PACU or ICU, whichever location is deemed necessary for that patient post-surgery. It is that nurse's responsibility to perform a post-operative assessment and compare that to the pre-established baseline. To focus on the literature for a moment, studies published by the Association of Anesthetists of Ireland and Great Britain profess a significant decrease in negative post-operative outcomes and a reduction in the length of patient stay when thorough preoperative assessments are combined with a follow-through in the delivery of care. Assessments are ingrained in us in nursing school, and the literature here supports that. According to Latanzi et al. In 2017, significant benefits in neurocognitive function were observed in patients who presented with more pronounced preoperative impairment. But how do you know this if you're not establishing a baseline? The NIH stroke scale was developed by the American Heart Association and is a valid tool in recognizing stroke severity, but it can also be used in clinical practice. In looking at the literature, it seems possible that cognitive function of carotid endarterectomy patients can be improved by surgical repair. Again, how can we measure the benefits in this patient population without establishing a baseline and without performing preoperative and postoperative assessments? More literature and more studies are needed on this topic. However, it is difficult to achieve those without sham surgery. This is a level 1 trauma center. It services a large service area, and patients and families need help finding resources. The Don and Kathy Jacobs Health Education Library found on the first floor is an excellent resource for patients and families. Also, the CRAMES database includes printable patient teaching handouts that can be taken home. In reference to best practices on this topic, there's a lot of positive work being done here regarding this topic. Emphasis is being placed on all pre- and post-operative assessments on all carotid endarterectomy patients But these assessments extend to carotid artery stent and thrombectomy patients as well. So what we're doing is improving the quality of care to a larger number of patients. It does require a multi-professional team, and this is definitely a large enterprise with thousands of patients and employees to consider. This is a stroke accredited institution. The stroke coordinator here has an enormous role in not only the educating of staff, but the safety of the patients as well. Patient charts are regularly audited, and specific unit education takes place when deficits are noted. Staff are trained on the NIH stroke scale every 2 years and are also required yearly web-based trainings. One goal of this project is to close the gap between contract employees and nurses of different experience levels, bringing them up to par for what is expected at this institution. A result of this project is a new badge buddy, and nurses love badge buddies. I have several myself. So nurses can attach this new badge buddy to their existing badge and use it as a tool to ensure that enhanced neuro assessments, vital signs, and wound and dressing checks are being performed on patients per protocol. A reflection of the personal effect of this practicum for me, to start, I have a greater appreciation for instructors and educators that have to create these PowerPoints and do these presentations because it is quite challenging. I am pretty sure I've recorded this 1,000 times. But on a serious note, this is a topic that I am very passionate about. My grandmother actually had a stroke in her 70s, and without deficit, fortunately. But in the years preceding her death at 90, she began having recurrent TIAs. So this is a topic that is important to me and kind of hits home for me. Seeing the NIH stroke scale in action was a great experience. And this practicum also afforded me access to areas that I typically don't get to see in my own practice. A project of this nature at an enterprise so large would seem like a daunting task, but this team makes it look effortless and logical every step of the way. I have certainly achieved a greater appreciation for the education department and have seen how much input comes from various departments in order to achieve a goal this large. The amount of teamwork that goes into ensuring proper communication between units is truly impressive. I personally only mention perioperative services in my project, but realistically, this project is quite large. It is an integration of educators, managers, directors, coordinators, staff nurses, you name it, everyone is involved. And our success on these projects directly affect the patients who are at the center of our care. Moving on to the PowerPoint, this is stroke recognition and prevention, highlighting the risk factors, signs and symptoms, and educational standards for monitoring potential stroke patients. To discuss the significance of the problem, this information was compiled from the American Heart Association in 2017, and cerebrovascular accident is listed as the number 5 cause of death, and we are all painfully familiar with the long-term disability that it can cause. As you can see at the bottom of the slide there, Americans are severely undereducated in the signs and symptoms of stroke. According to the American Heart Association, approximately 1/2 are unfamiliar. That is where we need to do a better job as nurses on teaching our patients and their families. Focus on the literature for a moment. Evidence suggests that the NIHSS stroke scale is effective in determining stroke severity, but it can also detect changes over time. According to Watanabe et al., carotid endarterectomy is proven effective in decreasing future risk of stroke. And then follow that up with Latanzi et al. In 2017, that carotid endarterectomy may offer more to patients than just prevention, but also improve cognitive function. To understand stroke a little more, we need to discuss the physiology. Stroke affects the arteries leading to and found within the brain. When a vessel is blocked by a clot or a clot ruptures, a stroke occurs. When this occurs, the brain doesn't get the blood and oxygen it needs, and over time, that part of the brain begins to die. The part of the body that is controlled by the damaged area of brain is negatively affected. There are 2 types of stroke. An ischemic stroke is where an artery is blocked, and a hemorrhagic stroke is a rupture of blood vessels, as can be seen on the next slide. As you can see here, this is your ischemic stroke, and this is the damaged area of the brain that's not receiving the blood and oxygen that it needs. And this is an example of a hemorrhagic stroke where a rupture of blood vessels has occurred and the blood is spilling out into the surrounding tissue. There are many risk factors for stroke. Many that we are familiar with: age, hypertension, smoking, diabetes, but I'd like to note a few that we may not commonly think of, which are certain blood disorders, and then also excessive alcohol and the abuse of illegal drugs. There are many risk factors that can't be controlled, including increasing age, sex, history of a previous stroke, hereditary, race. What we need to focus on as nurses are those risk factors that can be modified, treated, or controlled. We need to discuss with our patients that it's important to take their blood pressure medicine, to check their blood glucose, to talk to their doctor about sleep apnea or other concerns like that. But if you notice, there are also some risk factors that simply require a lifestyle change. And this is, again, where we can help as nurses, help patients and families find the appropriate resources if they're interested in smoking cessation or Alcoholics Anonymous, or if they have some form of drug problem that they'd like to discuss. The symptoms of a stroke: numbness, weakness of the face, arm, leg, especially on one side, confusion, trouble speaking, loss of coordination, sudden headache with no known origin. Some patients might describe the worst headache they've ever had in their life, and they have no idea what caused it. This leads us to the BFAST acronym. BFAST acronym is great. Nurses love the BFAST acronym. It's very easy for us to teach to our patients. It's easy to understand. Balance, eyes, face, arm, speech, and time. And I'd like to emphasize the T for time there, because if our patients and families take anything with them when we perform this teaching, it's that to know if they notice the warning signs for a stroke, that it's time to call 911. As nurses, we all know that time equals brain. Carotid artery blockage. The carotids are large vessels that carry blood and oxygen to the brain, like we discussed earlier. They can narrow due to health issues, influencing factors, increasing age. A healthy carotid should be patent with a smooth lining, but things like hypertension, diabetes, smoking, those can cause the walls to become rough, and when this happens, it allows cholesterol to build up. When the plaque inside the vessels clots, blood clots can stick to that plaque, and when a clot breaks off, that's when a stroke occurs. The NIH neurological assessment includes 11 domains, and these include sensory, language, speech, and vision. The domains are scored 0 to 2, 0 to 3, 0 to 4, and a total score is calculated. And as you can see on the left side of the slide, this is how you can determine the severity of your stroke symptoms. The next two slides are the monitoring standards as established by this institution. If you are interested in checking those out, there is a link at the bottom of each slide. Again, these are for this institution. They include pre and post-operative, as well as detailed vital signs, neuro checks, dressing checks, and this is the information that is found on that new badge buddy that's coming out. This is all pretty exciting. Lastly, I'd like to follow up with patient and family education. It is important for us to encourage our patients to take their medications as directed, not to skip doses. Be sure that we let them know that just because they start feeling better, that doesn't mean it's okay for them to stop taking their medication. We also need to educate patients on the risk factors for stroke, and we need to assist them in finding the appropriate resources to help them reduce their existing factors. We need to teach patients and families the warning signs for TIAs and strokes, and also ensure that patients and families know what to do if they notice the warning signs of TIA or stroke. These next two slides are the references, and with a link for each one for all of the information that was provided here. Again, my name is Kim Cornelius. This is, or was, the Stroke Recognition and Prevention, highlighting the risk factors, signs and symptoms, and educational standards for monitoring of potential stroke patients. I appreciate your time, and thank you for listening.